Thank you so much for dialing in to our session this evening. And tonight we're in conversation with and talking about essential information on HRT and menopause. And the goal here is really to answer your questions that you have in practice. So a few quick domestics just to get us all on the same page. We will be recording the webinar tonight, so you can access again, so should you need to. If you could, please keep all your microphones on mute. You can have your videos on if you wish, but if you're having any connectivity issues, maybe just pop off your video and that should improve your connection. Equally, if you have any issues with the sound, just check your own speaker just in case it's the volume or if it's muted on your laptop or your computer. And if that doesn't address it, maybe log out of the call and log straight back in again, and we'll see if that addresses it for you. Our plan tonight, so you can use the chat function and we'll take any questions from there. We will be using some anonymized information from the webinar later, and there will be a survey if you don't mind completing it, just to give us some insights into how you're getting on. So Grace has kindly popped that in the chat there, so you can access that later. Okay. So tonight we have the pleasure of being in conversation with Dr. Deirdre Lundy, and she is the clinical lead for a complex menopause clinic inside in the National Maternity Hospital in Dublin.
Thanks a million. I'm going to kick off really quick because I have a million slides and I don't want to dwell on them. I want to try to get straight into as many of your questions as I possibly can. So Ruth, can you confirm, is that looking okay from our point of view?
That is perfect, Deirdre. Thank you.
Great. Okay. And apologies now, if I bomb through some of these maybe quicker than you think I should, it's just to give us more time for questions at the end. So I do apologize. So let me see if I can get my thing to actually advance now. Let's see what's happening. There we go. So as you know, those are the declarations. You got to tell everybody you ever took money from, which for me is pretty much everybody. But I can very much confirm that everything on these slides is going to be validated through guidelines or publications and nothing got to do with pharma promotion. Quite the opposite, you know. So a couple of really quickie background. I apologize, it's very rudimentary. Most people know this stuff, but it's always, I think it's a good idea to just go through it and make sure no one's getting left behind. So the word menopause is a gynecological term. It means the last day of the last period a person will ever have, and it's usually diagnosed in retrospect by saying, oh, you're over 50 and you haven't seen any periods for a year. Generally, though, that's not how people use the term in general practice and among the ladies these days. The word menopause really is kind of a blanket term to kind of describe people who are going through the hormonal transition where you go from having full ovarian function, full potential reproductive capability, full hormonal release to almost none. You can identify when it's approaching in the lab by taking things like anti-Müllerian hormone levels and inhibin B levels, but those things are not really available to us in general practice. So while there are hormone blood tests that can help confirm the approach of the final menstrual period, they are not accessible to GPs in this country. So mostly how we diagnose menopause is by talking to the patients and actually getting them to tell us their symptoms. Now, why is this of relevance? Well, from a pharmacy point of view, even though menopause, perimenopause is not necessarily considered a disease, it isn't unless it happens at a very young age. But while it's a natural transition, it's as natural as a heavy, painful period or as natural as a rotten cycle disruption at puberty. It's the kind of thing that can have a big impact on quality of life, often drives people with disability into the GP to get advice, and it often ends up with a prescription of some kind. So from that point of view, it's really important that everybody dealing in primary care or the pharmacy level who have female patients be as knowledgeable around perimenopause and menopause and hormone therapies and non-hormone therapies as they would with kids going through puberty and people with pregnancies and period disruption. The perimenopause is the time of menopausal hormonal disruption when you're still having cycles. So this often happens in the middle to early 40s into the early 50s. People have to be careful because even though they're getting maybe flushes, sweats, mood changes, cognitive dysfunction and all the rest of it, they could still get pregnant. And we do see it happening from time to time. We have that confirmed with data from our medical termination clinics, where a lot of people over 48, 49 are seeking medical termination, where they never thought they had any risk to pregnancy. So that's really, really important. As I said before, there is no serological way to diagnose perimenopause. You kind of know someone has bled their last bleed if they're a good 6 to 12 months after their final period and their FSH levels are above 35. But we would rarely bother with those blood tests unless there was some other issue, you know. The most effective way to control the symptoms of the perimenopause and menopausal disruption is with hormone therapy. Because if it's a hormone disorder at its core, obviously stabilizing and supplementing the hormones is the way that you fix it. HRT, as we know it, hormone replacement therapy, is so benign and so safe these days. It is far more healthy and helpful than any form of contraceptive pill. And yet, in some cases, prescribers are so much more frightened of HRT than they ever are about starting or changing the pill. It's kind of like, to me, it's a bit ironic, but that's just it reflects our poor training, I think, you know. These are the cardinal 20 symptoms of perimenopause, menopause. They're not the only symptoms. And I've seen lists as long as like 150 things. But these would be the big ones that we typically see. So if somebody comes in and they're over 40, 45, and they're describing symptoms like some or all of what you're seeing there, and it doesn't always have to be all of them, it can be just one or two, that's perimenopause until proven otherwise. And these people are entitled to a trial of hormone therapy if that's what they're interested in. Now, there are some people who can't try or shouldn't try hormone therapy. And that's what the specialist clinics like the one I run are all about. That finally the HSE has commissioned specialty services where we deal with people who have other morbidities that make it difficult sometimes for the primary care doctor to prescribe HRT, you know. These are some of the guideline basics. So all patients should be able to talk to a prescriber or a therapist or somebody about what to expect in perimenopause. Yes, we have lots of good drugs, but that shouldn't be the entire story. There should be a more holistic approach, an individualized approach, which I think we do, but it varies, I suppose, from doctor to doctor and surgery to surgery, you know. There is no absolute ban on age with regard to hormone therapy. A common phenomenon these days is people who are maybe 10 or more years since their really severe menopause symptoms are starting to think, God, did I miss out back then when I was like 50, now I'm 60? Should I still have the occasional flush or sweat? Is it too late for me to start HRT? And the answer is no. It is never too late. You're never too old to try HRT if you have persistent symptoms. The unfortunate truth is if you're more than 10 years past your last period, then chances are going on some kind of hormone support, ovary hormone support, won't give you any cardiovascular protection. That's the only negative about that. But it doesn't mean you can't try it. A separate kind of entity or a particular entity that arises in perimenopause and menopause are the changes that people experience in the genitourinary syndrome. So these are things like we used to call atrophy, dry, uncomfortable vagina, excessive urinary tract infections, frequency, nocturia, difficulty with penetration, and all the other myriad of things in between. This is now known as a collective term, genitourinary syndrome of the menopause. And genuinely the only treatment for that is local vaginal estrogen. So when somebody comes for something like Blicel or Vagifem or Vagirux or Ovestin or whatever, even though it is HRT, and you'll find it among the HRT pages in the BNF and the MIMS, it is an HRT. These products are confined to the genital area, to the vagina for the most part, and vulva. And people who have all sorts of morbidities that would generally make us pause before we'd offer HRT can safely go on local vaginal estrogen. When it comes to the non-prescribey ways to manage menopause and perimenopause symptoms, there's a load of things that can be addressed. But as you well know, with your average 12 to 15-minute GP consultation, it's very unlikely that all of these things will get discussed in that time. But these are really important aspects, like eating better than you usually do, moving as much as your body will allow, weight management, and as we know, that's an emerging field in pharmaceuticals, checking your smoking and vaping and alcohol habit, and then getting support and making time for yourself and trying to deprioritize other people and start to prioritize yourself for a change. That's a real big ask for a lot of women, but that is an important part of self-care in perimenopause and menopause, you know. People who I mostly worry about, like seriously worry about menopausally, are very young women. So women under 40 who have no periods or gappy periods and are getting some, all, or a few symptoms. Particularly girls under 30 need specialty care. And we have a special clinic for them in Hollis Street. We call it the Premature Ovarian Insufficiency Service. And they get priority bookings because nobody under 30, certainly nobody under 30, nobody under 40 should ever be devoid of sex hormone. That is dangerous. And then people who've had their menopause put on them as a result of chemotherapy, radiotherapy, or having had their ovaries, tubes, womb removed. We tend to prioritize those ladies as well. Their symptoms tend to be a little bit more powerful, you know? So these are the very special precautions. These are the people that I deal with almost exclusively. So someone who's had a diagnosis of breast cancer recently or in the past, even if it was a triple negative breast cancer, they should avoid HRT unless all other things have proven to be unacceptable. And that would make up about 80% of our patient load. And I think we're doing good work. We can't help everybody, but I think we help a good few. Severe porphyria, blood dyscrasia is actually a spectrum disorder. When it's mild and not kicking up, you could probably get away with HRT, but if it's kicking up, you definitely want a hematology intervention and specialty menopause advice. Severe or active liver disease is another big one because, as you know, all of the hormones that we use will eventually end up in the liver. Even if we bypass first pass, they're all getting there ultimately. The other big sort of subcategory that we deal with are people who've had blood clots. So people who've had blood clots have to avoid oral estrogen, and they have to avoid the strong estrogen that comes in the Evra patch and the NuvaRing contraceptive ring. All of those products are thrombogenic. Even stuff like Femitab or Novafem or Clyogest, those are thrombogenic estrogens because they're taken in orally or they're very active molecules like the ethinyl estradiol. They go through first pass, they activate clotting factors, and they can actually promote blood clot. Either another one, if you've had one in the past, or your first one ever. So while I do give HRT to ladies with a personal past history of blood clots, I'm very cautious about how I deliver the estrogen. I'm very cautious about the type of progestogen I pick, and I also watch the doses. And that can be tricky sometimes because not every young woman gets by on a low dose. People with serious other gynae issues like irregular vaginal bleeding, endometriosis, fibroids, cancers, any kind of reproductive cancer, we do have to be careful, but it's not a blanket no for those people. Ideally, a thorough history. We don't usually do a big physical examination, I have to tell you. The only thing that we're mandated to do by the British Menopause Society is a blood pressure and get a ballpark weight, BMI. Beyond that, when it comes to things like doing a vagina examination, unless they need a smear or they've had some weird symptom that needs investigation, nobody needs screening PVs and screening smear tests. And we certainly don't do clinical breast examination unless somebody has found something and wants some reassurance. So when it comes to actually laying down the law about, can I use HRT? What kind am I going to use? How am I going to put it in? What are my progestogen options and all of that stuff? It really helps to get some background kind of comfort zone when it comes to the products themselves. So back about 10 years ago, it was commonly accepted amongst doctors, nurses, everybody, that HRT caused breast cancer. Even though that is not true, it wasn't true 10 years ago, and it isn't true now. HRT is not a carcinogen, and there's no data to suggest that it has any kind of a de novo impact on healthy breast tissue, turning it into malignant breast tissue. No. But we do know that breast cancer is the commonest form of cancer diagnosed in women after skin cancer. If somebody is going to get malignancy in their breast, most of them, not all, but most of them have estrogen and or progesterone receptors on the cell wall and the mitochondrial wall. So there is an arguable relationship between the amount of estrogen in your blood at any given time and whether or not malignancies in the breast start to develop and materialize either as a palpable lump or something you see on a mammogram. But it doesn't be cause and effect. It's like a promoter in risky women as opposed to taking a healthy woman and giving her breast cancer. And that makes sense. I mean, it's the reason why most people who've got ER positive breast cancer diagnosis will be offered something like an aromatase inhibitor or the tamoxifen serum, because those drag down the estrogen levels, and actually survivorship and recurrence rates have been shown to be improved if you give estrogen blockers. So this is the data from the WHI study on breast cancer and HRT use from like 23 years ago. And it's really, really illustrative for patients who are nervous. So if you take 1,000 women who are over 50 but under 60 and you do mammograms on them, you'll find about 23 cancers per 1,000, because that is the normal background rate for people in that age group. If every living one of those 1,000 ladies has been on a strong oral HRT combination, estrogen and progestogen, and you do those mammograms, you'll find 4 extra cases of cancer. So there is a promotive effect in some way. But if you jump down to the number of women being diagnosed with breast cancer whose BMI is in the overweight obese range, it pales in insignificance. So while using HRT does have an impact on your personal risk of being diagnosed with breast cancer, to compare to other things that we take for granted sometimes in our life, it's not that big of a deal on the grand scheme of things. This is for healthy women who haven't already been diagnosed with breast cancer, you know? There's a bit of data here I'm not going to go into in any depth, and it's actually looking at that slide dates from 2002, so 23 years ago, when almost everybody in the world who used HRT was using the oral horse's equine estrogen and Provera, strong Provera, 10 milligrams. If you actually look at more recent observational data, that was an RCT, this is observational data, we're actually not seeing that much of an impact, because almost everybody in Ireland, certainly, and in most of the UK these days, are on lower doses of estradiol, whether it's the oral 17 beta or the transdermal gels, patches, sprays, where the impact on breast cancer risk doesn't seem to be as great. So that's very reassuring. Now, there is still a relationship. You can't say that it's a get out of jail free card, but it is actually better than it was 22 years ago, thank God. Other things that give us pause, obviously the breast cancers. Certain types of ovarian cancer have to be treated sensitively because they are estrogen driven, although most ovarian cancers are not the popular ones, not the common ones. And again, some types of endometrial cancer are very estrogen driven, but others not so much. So this is from the This is Gynae Oncology website. This is Professor Donald Brennan's slide about HRT after cancer generally. And he's broken it down into very broad strokes of should not have HRT, might have HRT, and absolutely should have HRT. And interestingly, if you look, you'll see things like vulva cancer and vagina cancer and cervical cancer, which do still occur in Ireland. And a lot of people think, well, it's the reproductive system, so obviously I can't have HRT. Yeah, not only can you, you absolutely should. Because often the treatment for those cancers is pelvic clearance. You're ended up essentially castrated, often at a young age. You need your estrogen replaced. This is last year's publication from the British College of Obstetrics and Gynecology, where it breaks down all the different types of reproductive cancers by whether or not they're highly estrogen sensitive, highly progestogen sensitive. So the column on the left is should I have systemic HRT, like the patches, the sprays, the gel? And the column on the right is, can I use vaginal estrogen? And as you can see, except for kind of uterine sarcomas, there's actually very few cases where a vaginal estrogen would be ever a problem for somebody with a reproductive cancer. And that includes pretty much most breast cancers. Some breast cancer specialists still have a little bit of a hesitancy around women using an aromatase inhibitor and a local vaginal estrogen at the same time, but they are the minority. And the vast majority of people in oncology services, when faced with a lady on an aromatase inhibitor who's getting a lot of genitourinary symptoms, they're normally like, just give it to her, she needs it, you know? I mentioned about having your ovaries removed or having them impaired by therapeutic activity with the doctor. So that we've already talked about that. We talked about that. I'm going to run through these really, really fast. Another thing that used to be an accepted truth, which no longer is we used to ever give HRT to people who had cardiovascular risk factors, like big ones. And then we certainly wouldn't prescribe HRT for someone who had had a cardiovascular event, like a heart attack. or stroke. And the case has actually changed. So nowadays, in the last 5 to 7 years, because we've got a lot of good data to support this, if somebody has had a cardiovascular event, but is now well managed on her statins, on her antihypertensives, getting her weight under control, stopping her smoking, and all the rest of it, not only is it safe to give HRT, there might even be a little bit of primary, secondary prevention of a subsequent coronary event. So that's another big category of patients that I deal with in my clinic, people who've had a cardiovascular mishap of some kind, and likewise with the blood clots. That's the data on the blood clots. And that's the nice Thrombosis Ireland, Thrombosis UK information leaflet for people who've had a personal history of a venous thromboembolism, saying that to be clear, you can use HRT, it just has to be transdermal estrogen. And we usually try to use a non-androgenic progestogen like Utro if they can tolerate it, do fast and at a push. Mirena is fine too, especially if they've had a blood clot and they're still on a blood thinner. Mirena could save them because they get so much heavy bleeding, you know. We definitely make a special place in our clinic for people who are living in with HIV. But I'll be honest with you, the referrals are few and far between because the infectious disease services take such good care of these people. And they do tend to go through menopause a little bit earlier. God love them. Endometriosis and adenomyosis, they're special cases. You got to be careful because the estrogen and HRT can cause an endometriotic flare. The progestogen usually helps, but not always. So we do have to watch those ladies closely sometimes. So now I've skipped really fast through all those theoretical slides and I want to move on to prescribing because that's really the nuts and bolts of this. So the core hormone of HRT is the estrogen. That is the drug. That is the hormone that controls almost all of the symptoms. Generally speaking, the progestin element or progesterone element of the cocktail is purely there for endometrial protection. Estrogen drives endometrial changes. Progestogen brings that back down to baseline. So you can't use one without the other. Lately, I've been seeing all sorts of kind of social media things about how progestogen alone helps my menopause and does this and does that. And the answer is it may have well helped you, but there is no data to say it's better or safer to just take the natural progesterone as part of your HRT and to avoid the estrogen. We generally feel the estrogen is the core. The ovaries also produce 4 different types of androgen, not as much as that the testicles produce, but it is in there. So we frequently add testosterone into the HRT cocktail these days, particularly for younger people under 40, 30, and particularly for people who notice a drop in libido has been a significant part of their perimenopause. The problem for you as dispensers and advisors is that how we like to mix and match and bespoke our HRT cocktails, it comes in all different shapes and sizes. And it's hard to know for sure when you receive a prescription, is this just a very experienced prescriber who really knows the ins and outs? Or is this some schnook taking a chance and hoping to God they get it right? And it's impossible, unless you know them personally, it's impossible to know which is which. Because as you probably know, I do a little work for Paul Ryan on the Pharma Buddy. And some of the stories and the prescribing practices you guys let me know about would make you cry. And I really feel your pain when dealing with some of the kind of numpty activity that goes on in primary care. But I'd like to think they're the exception. And for the most part, we're all trying to be on the same page. So I apologize at the outset. Lots of people just take estrogen. And these would be hysterectomized people who are wearing a Mirena coil that's only been in there for the last 5 years. That kind of a group. So they don't need any progestogen unless they particularly want to take Utro for sleep. So these are the products that are available currently in the MIMS. Divigel, I believe, is available, as is Estrogel. The patches, don't get me started. You can get some kinds, but not others. People are very particular about which patch they'll put on. They'd rather change their product altogether if they can't get their brand of patch. I understand that. We also use a lot of Lenzetto. I love Lenzetto because I can mess with the dose over the phone. I don't have to send her a new prescription, but it also means that she can mess with the dose without telling me about it. So Lenzetto has pros and cons. And then all Everel, of course, and Everel Conti. And then we have all the different tablets like Estrofem, Estrogen, Femitab, and so on. These are the dose equivalents. So as far as the British Menopause Society is concerned, when a person's on HRT, they should all start around a kind of a lowish dose. So 25 to 50 microgram patch would be a good starting dose. That's the same as 1 to 2 pumps of estrogel or a single sachet of Divigel. They call Sandrina Divigel in the United Kingdom. And that's the same as about 2 to 3 sprays of Lenzetto. But the bloody company won't come down and give us a dose equivalence for Lenzetto. They refuse to commit. So the truth of God is we don't really know how much Lenzetto is 50 micrograms. So I'm guessing it's somewhere between 2 and 3. But every prescriber might have a different concept of that. Certainly, I would never go more than 4 sprays a day for a woman of an average age. I would only ever use a lot of Lenzetto in the very young girls, you know. When it comes to what progestogen to use, there are really only a handful of approved progestogens for HRT purposes. You can't just use the mini pill. It doesn't work like that. So probably the most popular in Ireland would be utrogestan, micronized progesterone. And we can get it in from all different countries. Sometimes the licensing will say for vagina use only. Sometimes it'll say for oral use only. Sometimes it'll say for vaginal or oral use. They're all the same utrogestan. We don't care what one you're dispensing. And generally, we give about 100 to 200 milligrams, either continuously or sequentially, depending on the menstrual habits of the lady involved. Every once in a while, with a heavy bleeder, we might have to go up high, or in someone who's on a big dose of estrogen. But generally, we try to keep it in the 1 to 200 range. But it's not a great progestogen for period control. It's very gentle and wonderful for the cardiovascular system, mostly tolerated and great for sleep when taken orally, but it doesn't shut down rotten periods. Whereas something like Dufastin tends to be more potent. Dihydrogesterone, 10 milligrams, 20 milligrams, 30 if you're stuck, really can help suppress reactive bleeding from the womb lining. So we use that a lot. Mirena, as you know, is really convenient for people who want one. But I'm sick to death of being sent in women who have no interest in a Mirena to get one put in, often not their choice, because the GP won't prescribe the HRT estrogen unless they get a Mirena put in. Not acceptable. We could easily go for a Utro or a Dufastin if she don't want a Mirena. Provera and Noriday are also suitable and licensed progestogens for HRT balance, but they're quite powerful and sometimes a little hard to tolerate depending on the lady. But everybody's an individual. We never say never. If a person comes into you and they're still menstruating, and if they've had a menstrual period anytime in the last year to 18 months, if you put them on a version of HRT where you take the progestogen every night, theoretically to suppress bleeding, they're going to bleed all over the place. It's going to be an absolute dumpster fire. So you should start people who have recently had natural periods on a form of HRT where the progestogen is taken sequentially, cyclically, not every night of the month, 2 weeks, 3 weeks, that kind of a thing. But good luck trying to explain that to some of the prescribers, because I don't think that message always gets through. So there's some DIY combinations, just kind of comparing how much of the estrogen you might use, what kind of progestogen you might use. These are the products that are listed in the current MIMS that are for people whose menstrual activity is well over. So she's a good 48, 50 years of age. She hasn't seen a period at all for 12 months. You could try her on one of these brands. But the only non-oral product we have in the MIMS is Everol Conti. We don't have any other nice combined estrogen progestogen patches. So that kind of limits our options a little bit. So as a result, we sometimes bespoke it. So we'll pick an estrogen from column A, progestogen from column B, and see what suits the lady in the long run. We already talked about this. Testosterone, like I say, lots of people want to try it. I have seen stuff on Instagram and TikTok where it solves this problem, that problem, the whole nut. The only thing there's any evidence to say it's beneficial for is low libido, or hypoactive sexual dysfunction disorder, as they're calling it these days. So like if somebody's coming in and they're using testosterone, they theoretically have had this discussion with the prescriber to say their sex drive has been affected by menopause. They want to give testosterone a try. But the problem for us is it's really hard to do this in Ireland, because the only licensed female dose testosterone in the world comes out of Australia in the form of Androfem 1. And by the time you've brought it in here, it's not covered by the free HRT. It can be 100 or plus euro. And like some people do want it and they ask for it specially, and the pharmacies are asked to order it in. I don't know how that works for you guys. So what we typically do is we say, well, look, we have male testosterone. We know the equivalent doses for females versus males. Why don't we just prescribe a male testosterone, but titrate down the dosing, microdose it to the female levels and see where we land? And then we monitor those blood levels regularly. It usually at initiation or before we started, usually 2 to 3 months later, and then ideally annually thereafter. Okay. Another way to kind of attack low sex drive for people who are in menopause, is tibolone. So tibolone is the progonadomimetic drug that comes in the form of Livial. Livial gets metabolized by first pass in the liver, and its metabolites have weak androgenic, estrogenic, progestogenic end organ properties. So it's a kind of cheaper, easier way. And unlike oral estrogen, oral gonadomimetics are not thrombogenic. So somebody who's interested in some HRT support for bone and symptom and well-being, but also has low sex drive, there's no reason on earth why they couldn't try Livial as a first timer as well. And those are the approved doses for male strength testosterone for a female who's using testosterone for HRT. So that's a hard thing in pharmacy, I would imagine, because you see all sorts of shenanigan prescriptions. Sure, Victoria just sent me an email, a photograph of somebody prescribing like male dose testosterone for a lady, no bespoke information, no leaflet to explain to her the off-label use of the product. Anyway, another big part, we said this already, is if you're still bleeding, you're still at risk of pregnancy. Or if you're having sexual activity, that puts you in danger of pregnancy. So HRT generally is not contraceptive. I mean, a Mirena is, but all the other stuff isn't. So you got to be really careful. And it's perfectly acceptable to put somebody on an estrogen, progestogen, HRT cocktail and the mini pill. We do that all the time, and that's perfectly acceptable. The one thing, and a Kylena or something like that. The one thing you would never, never, never do is prescribe any form of combined hormonal contraception, the pills, the patch, the ring, and HRT. In those cases, it's one or the other, never both. So be careful if you see somebody who's dropped the ball from that point of view. So early menopause is diagnosed, or premature menopause is diagnosed. People who are less than 40, who haven't bled regularly and have gone for at least 3 to 4 months with no periods at all, who've had a single random follicle stimulating hormone blood test done by the GP, and it has been found to be elevated above 25/30, that is a POI diagnosis. Those people are at high risk for future health issues because of estrogen deficiency in younger life. And here the onus is really on us to prescribe and to maintain them on estrogen supplementation, whether that's the pill taken constantly without breaks or HRT. It's a different situation for girls under 40, people under 40, than it is for people over 40, 45, 50. So that's why I think it should ideally be handled by specialty services or by an endocrinologist who has an interest in early menopause, which is not every endocrinologist, by the way. You'd want someone good. Like we love Lisa Owens in James's hospital. She's an expert on things like hormonal disruption and polycystic ovarian disease and early menopause and stuff like that. Almost all the HRT prescribed in Ireland is done so in general practice. The Irish General Practice Nursing Association is really up in their game by training their practice nurses to become comfortable and knowledgeable when it comes to advising patients, even though it might be the GP who's ultimately writing the prescription. And that's really going gangbusters, so it is. So things are getting better. But obviously, you guys need to be vigilant because there are some people who've fallen through the cracks and really shouldn't be prescribing. And then there are some patients who should only be managed in a specialty center and not in primary care. So I think that's really important. For people like those ladies with the breast cancer or the sarcomas or the people who have really been told, ideally, you should avoid HRT at all possible, this is the absolute laundry list of stuff that the British Menopause Society have suggested we could explore with suitable individuals who need menopause support, but who have been told to avoid HRT if at all possible. So you're very familiar with the fact that the SSRIs and SNRIs, up to a point, can improve things like flushes and sweats. And obviously, they do help with things like PMS, PMDD, and the mood disorder that often accompanies menopause transition. Off-label antihistamine for sleep improvement, not ideal. We do not want people on antihistamines in the middle of the night long-term. But for short-term difficulty, it can happen, drowsy antihistamines. The neurotropic drugs like GABA and pre-GABA, we do use them, particularly for people with the neuropathic pain that aromatase inhibitors often create. We use oxybutynin and anticholinergics sometimes, even in people who don't have overactive bladder, because weirdly, that can actually dry up flushes and sweats, just like it dries up bladder sensation. They can also dry out everything else in your body, so you got to be careful with dosing, and we usually go in very slow and titrate up. Clonidine, weirdly, is the only drug in Ireland that actually has a license for flushes and sweats other than HRT. It's like probably the least effective form of non-HRT therapy for people in menopause. I never prescribe it because you got to be so careful that it doesn't drop the blood pressure so low that the poor woman falls down when she bends over to pick something up. And then lastly, and I'm happy to answer questions on these because I'm really into it, the neurokinin 1, 3, and 4 receptor antagonists are starting to hit the market hard. As you know, we have one approved at the moment, which is fezolinetant. That's Veoza. She's very effective for flushes and sweats. She is not, however, firmly licensed for people who've had treatment for breast cancer. So using it in that context is still off-label, although we do it. And there's a new one coming out. It's elinzanetant. It's an N1 receptor antagonist. It's just got FDA approval in America, and its European medicines approval should be imminent. I think it may have already happened. But when the EMA looked at it, they did not approve it after breast cancer. So we're still waiting on more support for those poor breast cancer ladies. Now, does that mean they can't go on Veoza or the other stuff when it becomes available? It's going to be called Linkuet. So elinzanetant, the new neurokinin drug, is going to be called Linkuet when it's available. Will they ever get a license after breast cancer? I think yes, eventually, but will that keep us from talking about it with patients currently? No, it will not. So don't panic if you meet a lady who's on an aromatase inhibitor, on tamoxifen, and somebody like me has also given her Veoza. We know it is not licensed. We are doing it cautiously with supervision. Other things that can help with symptoms in the menopause, CBT, if you can get your hands on it, is pretty damn good for things like flushes, sweats, and mood. For sleep, there's a special kind of CBT called CBT-I, the I meaning insomnia, which can really help. For things like joint pains, which is so common of women with aromatase inhibitors, movement like gentle yoga, acupuncture, reflexology can help. And like I said, never hesitate to throw some estrogen in that vagina, because there's almost never a case that it's unsafe to do so, and the patients will love you forever. In fact, in the United Kingdom, local vaginal estrogen in the form of like what Vagifem is, Vagirux, is now available over the counter. The trade name there is Regina or something, but that's how benign and safe it is. So before I finish and start answering questions, I just want to show you some resources. First of all, this is the booklet. I don't know if you can see this. That thing on the left is a link to, I think it's the Conciliant Health website that myself and Quiva, I think it was me and Quiva Hartley out of the Rotunda, we did a how to manage menopause, how to prescribe HRT, how to mind the side effects if people are getting side effects from HRT. I'm not sure that there's a lot of hard copies left, these desktop copies, but the digital version is available on the Conciliant Health website, so go for it. The thing in the middle is Brian Kennedy, Dr. Kennedy from down in Limerick. He started this WhatsApp group. It's actually a Telegram group for people who prescribe HRT. I don't know that he's actually invited pharmacists yet, but he bloody well should. But anyway, that'll be another thing that we could look at. But even if you're not getting access to that resource, which is very helpful, the Menopause Society of Ireland, which is only just 2 years old, its reinvented version is 2 years old, actively recruiting people from pharma, because we work as a team with you guys. If we're not all on the same page, we're not getting good health care done. So I'm going to shut up. Ruth, have you got anything?
I do. So guys, if you have any questions, pop them in the chat. So I have one quick question here. Could you just quickly repeat what you said about HRT and contraception being used concurrently?
Yeah. So it's perfectly acceptable to use some form of HRT or any form of HRT, estrogen, progestogen, and contraceptive hormones at the same time, except for the combined hormonals. So you can use HRT, estrogen, progestogen, and Cerazette or Azalea. You can use all three. In fact, you should do, because most of the progestogens that we use for HRT balance are not license for contraception. That's the problem. Say somebody has a tiny little womb and never had kids and they need contraception and they got a Kylena. Well, she can't use the Kylena for her HRT. Say she's got an early menopause. But you can give her HRT, estrogen and progesterone, while she wears the Kylena. Even nonsense like Depo. A person can be on Depo-Provera for contraception, which is like a bazooka-strength Provera. You would imagine that's perfectly safe to just give her estrogen on top of that? No, you're not supposed to. You're supposed to give her oral progesterone or Everil Conti or something on top of it. So the rules are very convoluted, but you're supposed to be on a separate contraceptive. Now, if somebody's just using condoms, that's perfectly acceptable too. She don't have to be on hormonal contraception if she doesn't want to. We're less comfortable about being careful because we have that conversation all the time. Will you walk me through what being careful looks like for you? 9 times out of 10, they're talking about withdrawal. And we know that the failure rate, conception occurs in 22 out of 100 women who use withdrawal contraception in the first 12 months. So that's not acceptable. You need something. If it's just a condom, that's fine.
Okay, super. Can a woman over 65 restart HRT?
Always. So the only time I would hesitate if she's been diagnosed with one of those kind of game-changing problems like breast cancer, serious cardiovascular events that haven't been completely under control. So like if somebody's had a heart attack or a stroke, she's working hard to get her blood pressure down and her statins in line, but she still hasn't got there yet. We usually wouldn't restart or give her HRT at that age until all that other stuff fell into line. But it's very common for people to come in and say, I was on HRT for a couple of years. I was told, oh, you should come off now. They did. They never felt well. They wished they could have gone back on. And now here we are 5, 10, 15 years later. They're over 60 and they want to restart. Of course they can. The only sad part of that is if they have been off HRT for more than 10 years, going back on it for symptom control in later life is perfectly acceptable. But what going back on it won't do for them is protect their heart. If you had stayed on it and you hadn't let a good 10 years of estrogen depletion catch up with you, we might have been able to prevent the natural hardening of the arteries and predilection towards cardiovascular disease that comes to all of us eventually in age. But that doesn't mean you can't go back. Of course you can. I started a lady, she was 81. She was on HRT since her early menopause at 41. So she was 40 years on Prem-Pac-C. And the GP understandably said, you can't be on Prem-Pac-C. You're 81 years old. You're going to get a blood clot. If you haven't, it's a miracle you didn't get one already. But instead of giving her an alternative, he just took it off of her. And she hasn't had a happy day since. That was 6, 8 months ago. So we immediately put her 81-year-old body back on natural progesterone, micronose progesterone, and a little bit of Lenzetto spray.
That's good to know. Okay. We've a lady, a patient who has a family history of cancers, different types of cancers,
Good
ovarian,
question.
endometrial, colon, and the GP wondering, GP wants to put her on HRT, but
Yeah.
the lady is very concerned about the
The
cancer.
lady makes the decision. So she is the bottom line. I mean, obviously you're trying to support her to make an educated decision, but if she has a fear, rational or otherwise, we have to respect that and go in another direction. So a family history of anything is not a contraindication to HRT. Like if I meet somebody who's thinking about going on the pill and she tells me her mom or her sister had a blood clot, and especially if she tells me her mom or sister had that blood clot in connection with hormones, like say the pill or pregnancy, I'm not prescribing that girl the combined hormonal contraceptive pill because family history is a contraindication. But that does not be true about HRT, especially when you're using the low dose gentle stuff. So if somebody says, I have breast cancer in my family, I had blood clots in my family, I have this womb lining cancer in my family, I'm like, that's good to know, and I will make a note of it. And you should be vigilant because these things can run genetically. But does that mean you're not allowed to try HRT? Of course not. Of course you can try it. People with cluster cancers in the family, like say the womb, the people get the womb breast or the womb ovary, that kind of a thing, and colon, they often have inherited congenital or genetic predispositions, like say Lynch syndrome. So Lynch syndrome is a pretty common enough inherited cancer condition where you're high risk for bowel cancer and womb lining cancer and breast cancer. So you're in a kind of a rock and a hard place. If you get a Mirena put in, that significantly reduces your risk of getting womb lining cancer. If you go on natural low-dose HRT, it significantly reduces your risk of colon cancer, but there's a tiny bump in the risk of breast cancer. So it's not a black and white situation for those kind of cluster cancer. And ladies like that, they would like to come into a clinic like mine just to have that conversation. But sadly, we don't have the capacity. So at the moment in Hollis Street, we'll only offer opinions to people, or appointments, I should say, to people who've been diagnosed with those cancers. So if you have BRCA in the family, or even if you know you have BRCA1, BRCA2 gene, I'm happy to write out a letter to the GP to say, this is what she needs to know. This is what you need to know. These are her options. But at the moment, we don't have the room to accept those ladies for counseling. We will eventually expand and see them.
Super. Some of the practical questions just around the patches. With the supply issues, are there some patches that are okay to have? And equally with the patches, some of them are not sticking. So are there particular brands that are better at
I know those rotten German ones, the Estremons, are absolute garbage. So I'd be inclined to not even stock them because we've had nothing but complaints about them. The adhesive is aggravating. They don't stay on properly. And you don't seem to get as much impact from them. And I wonder if it's a local inflammatory process from the bloody adhesive that's somehow affecting absorption. So I know Victoria, I'm always talking about Victoria because she and I talk all the time, but I know she's had some good success with getting Vivelle, Vivelle. So it's almost an identical brand to Estradiol. And it seems to be just as acceptable to the old Estradiol ladies as Estradiol was. So that might be something to explore on the ordering system if you have access to that product. Things like Estraderm is okay. Everel is fine if it suits the lady. But as often as not, you're better off kind of segueing over to sprays or gels if they've had multiple problems with patches. Can you cut patches? Officially, no. Unofficially, oh, yes, you can. We do it all the time. In fact, I'm wearing a half 100 at the moment because I'm just so lazy. I could be arsed buying 50s. And it's actually easier to get hundreds than it is to get 50s, if you know what I mean. So give me 600s. I'll cut them in half. And I would happily prescribe that for a patient, even though it hasn't been actually studied. The only thing you got to be careful about is that people, and I'm not going to say because it's menopause, it's not just about menopause, but there are people who get it, patients I'm talking about, and some patients who just, they won't do this right. And you're better off using propriety brands where the explanation is exactly as the product information leaflet says. Otherwise, it's going to go pear-shaped, like definitely. Yeah.
Okay. Is it okay for a lady to be on Ovestin, Vagifem, and an estrogen patch?
Yes and no. So Ovestin and Vagifem are kind of double team in her vagina, as it were. So Ovestin is estriol, E3, which is a very active local vaginal estrogen. It's particularly useful for people with vulval disorder because being a nice light cream application, instead of squirting it right up the posterior fornix of the vagina, you can just put a tiny finger dribble around the clitoral area, the urethra, and it can help tighten those valves and keep those ascending germs out of her bladder and minimize urinary tract infections. But some people say, well, when I rub it on my outside vulva area, it really helps with that stuff, but I'm not really absorbent enough to get the comfort for penetrative sex. So some people do both, but you got to bear in mind that you are doubling up the dose with using the Ovestin and Vagifem at the same time. So as you know, Ovestin's kind of lead-in is nightly application for 2 weeks, then twice a week thereafter. Vagifem is the same. So I would say to a lady who finds she's better off using both, alternate them. So one, if you do Mondays and Thursdays, right? On a Monday, you use your Ovestin. On a Thursday, use your Vagifem. On a Monday, you use don't do both every week, if you know what I mean.
That makes sense.
Yeah.
Okay, we have a patient who was diagnosed with breast cancer, taken off the HRT, they tried the venlafaxine, they tried the Veoza, and then stopped by the oncologist. And the main issue the patient has is flushing and sweating. What would you recommend?
And I wonder why the oncologist stopped the Veoza. See, I would need to know that because we're on the precipice of getting licensing for the use of Veoza after breast cancer. So unless they have a very strong reason to deny that woman access to it, I don't see why she was discontinued. Now, some of our ladies have had to be discontinued because very rarely, and I'm talking about maybe 1 in 800 people, get liver enzyme changes on Veoza. So when I prescribe it, before I start it, and every month after I prescribe it for the first 3 months, I do liver function tests. And I watch those ASTs and I watch that bilirubin to make sure I'm not precipitating something. So maybe this poor lady had to come off the Veoza because her liver kicked up. That's a possibility. But if an oncologist just pulled the plug on her Veoza, I want to know why.
Okay. Can you swap the time of the day for the Utrogestion? Could they take it in the morning rather than the night?
Sure. The problem is not everybody, but most users of Utro who take it orally get this soporific effect where it makes them nice and kind of dozy and calm and kind of relaxed, which is fine if you're sitting around the house getting ready for bed. It can be problematic if you're just trying to get the kids out the door and go to work. So if you're somebody who tolerates oral Utro without any kind of sleepy time effect, take it in the morning. That's absolutely no problem. But if it does make you drowsy, you're better off taking it before bedtime. And if it's making you too drowsy, use it vaginally. And then you don't get the soporific effect.
Yeah, makes sense. If you have a patient who has intellectual disabilities, how would you support them in diagnosing or managing their symptoms?
We work with people who have intellectual delay all the time. It's really difficult. We have a big cohort of ladies living with Down syndrome who unfortunately go through perimenopause in their 20s, typically. So they're really struggling. And then often they're in supervised accommodation in workplaces, and they're getting heavy menstrual bleeding and sweating and flushing and sleep disruption and mood disorder. And it's really, really unfair for people who are maybe struggling already. So there's amazing resources coming out of Australia where people who struggle to read and process written word, it's like a picture book of my menopause, almost like a child's reader. And then some of my colleagues, Karen Soph down in Killarney and Kerry, she's done amazing work and has done publications on how best to manage people with intellectual issues and menopause disorder and hormone use. Mostly when we meet people, we see them with their shelter or care worker. So the three of us together as a team talk about options and make decisions. And that is like as if somebody had to have a guardian ad litem in the room at the same time. That is actually the best way to proceed.
Super. With estrogen, do you increase the dose gradually or do you add in new products? Because they've seen with items and scripts up to 3 different types of items.
That's a fabulous question. So it has come to our attention, particularly in private practices. I am a menopause expert kind of practices, which anybody can call themselves and don't necessarily have the training to back it up. That if somebody says, "Oh, I felt a little bit better, but not great," up a dose, up a dose, up a dose, and you get these monstrous doses of estrogen going into relatively older women who theoretically should not be on them. And then the more estrogen you feed the womb lining with, the more bleeding disruption you get, and we don't know what the potential harm might be in the future. So nobody should really be on doses more than 75, 100 at a push if they're over 45. Under 45, and particularly under 40, 30, I would often have to go quite high with my estrogen doses. So if you're a typical patient, 45 to 55, classic symptoms, I just want to get some sleep, I'm dripping wet all day long, every night I'm changing the sheets, putting down a towel. You start with a 37 or even a 50 patch, or 2-3 squirts of Lenzetto, or 1 to 2 pumps of the gel. And you give it 3 or 4 months. And that is absolutely mandatory because it does take time for people to evolve change. If they come back at that stage and they say, something is good, but it's not great, I do not automatically go to 75, 100. I now say, okay, maybe you don't absorb the estradiol as efficiently through your product as you could do with another product. Let's change the delivery system. So let's keep you on the 50 dose, but let's go to the spray or the gel or the patch or whatever they haven't tried. And we have had so much success with that, rather than going down that slippery slope of let's try 75, let's try 100, let's try 125 until it's a big old mess.
Okay. We have a patient who's went straight into menopause after chemo, but with the HRT, neither the patches or the gel were supportive, and it's sleep and sweats that are the issue. What would you recommend?
They should, I mean, I don't know what the chemo, what kind of cancer they were
They
for.
had non-Hodgkin's lymphoma.
Yeah, that is, we'll take those ladies in our service. So I don't know where that person is working, but if the person's in my catchment, you get the GP to send her in to me, I'll sort that out. That's not a problem. And even if, you know, if she doesn't have access to really good menopause care, like in the private sector, like every county in the Republic of Ireland is supposed to be serviced by a good menopause specialist. The problem is not everybody's service is running as efficiently as everybody else's. So sometimes what the prescribers do is they get on the phone. I'm going to put my phone. So they get on that Telegram app I talked about. So the GP can join the Telegram app and say, I have a lady with non-Hodgkin's lymphoma. I tried this, that, and the other. I'm not making a dent in her symptoms. What can I do? And then me and Brian and Rachel and Nicola will get back to them straight away with advice.
Super. A patient in late 30s with night sweats and no other medication. What would you recommend?
That's weird. I mean, if she's having regular periods, then I'd want to wonder what the hell's going on. Quite recently, I had a woman with debilitating night sweats who was not responding at all to HRT. And we eventually did some digger deeping. We found an elevated white cell count and a focus of real tenderness in her left iliac fossa. She had a tubal abscess. So other things make you sweat. Not every sweat you have is menopause, and it's certainly not when you're in your 30s. So if she's menstruating regularly, if she doesn't have an elevated FSH, it is probably not hormone driven. It's probably not an ovarian hormone problem. Something else might be going on.
Okay. If a patient is hospitalized with acute medical illness, would you withdraw the HRT?
Never. So that's a big one. It happens all the time. Oh, I went in with, I broke my leg, or I had this, that, or the other, and they immediately made me take off my patch. People on transdermal estrogen under 50 micrograms, in or around 50 micrograms, are no more likely to get a blood clot than anybody else. So if somebody's really unwell, and now on top of all their drama, you've actually stripped them of their estrogen, you're actually going to make them worse. And every hospital pharmacist knows that transdermal estrogen and natural progestogens are non-thrombogenic and do not need to be discontinued on hospital admission, with bed rest, with general anesthesia, with pelvic surgery, none of it. But do you think the surgeons and the specialists are talking to the hospital pharmacists about this? I don't think they are.
If an element of the combination HRT is unavailable, do you withdraw the whole regime or just continue with the bits that you have?
I just chop and change, to be honest with you. I'll make do, like I'll, kind of MacGyver it sort of a deal, So what I need a specific, if you could give me so this happened, I could tell you what the fix is, if you know what I mean.
Sorry, I don't know. Fionn, can you add in a bit more there, and I'll try and find it and come back up to Fionn's question.
Yeah, so like it's not uncommon for people who are say on Everil Conti, which, as you know, is a 50 microgram estrogen delivery system that has 170 odd of the northisterone acetate blended into the same patch. Somebody will come back and say, I think I need a little bit more estrogen. Can you now bump up the estrogen with a bit of Lenzetto or a half of an Everil? Generally, we suggest no. Whatever you do to the estrogen, you should match it with the progestogen. So I would rather see somebody use a full Everil Conti and a half an Everil Conti at the same time, rather than bump up the estrogen on its own and not fiddle around with the progestogen. Yeah. Because that's the biggest problem we have. We constantly see women being referred, urgent postmenopausal bleeding referral to gynecology because they're bleeding on HRT. That is not postmenopausal bleeding. That is iatrogenic bleeding caused by a dumb prescriber who didn't match the progestogen with the estrogen.
Okay.
Don't tell them I said that.
Yeah. Okay. What do you think of the combined oral contraceptive pill Zoli for perimenopause bad periods? Can that contribute? And does this form of estradiol offer any HRT benefits?
Okay, so she's good. Another one that's really good is Drovelis. So the new estetrol pill that has the drospirenone in it. It's a 24 active 4 gummies. Just like Zoli, the problem with both of those products is they're excellent for young women in menopause. We use them all the time for the POIs. You can't take a break. So the 4 dummy pills need to be dropped and you need to go straight on to the next package. I seen a girl recently. She was diagnosed with POI at 21. And for the next 8 years, she used Avranet, 21 days on, 7 days off. She had osteoporosis by the time we met her at 31 because the numpty was withdrawing the estrogen for 7 days a month. These people need constant estrogen support. So if you're going to use the combined oral contraceptive products as an alternative to HRT, that is fine, but no estrogen-free days.
Okay. If you have a patient who's on Mirena for a long time, how will the patient know if they're menopausal?
They won't. So we sometimes do random FSHs for people who've had a Mirena for 8, 9, 10 years, haven't seen a period in all that time, and they're not even sure whether they'll even have another period. Generally, we know that the need for contraception ends at 55. Even if you're still actively bleeding bang on every 28 days, never in the history of medical literature has a woman over 55 conceived without help. So you need kind of fertility intervention if you're going to get pregnant after 55. So a lot of women have their Mirena removed at 55 because they figure, well, I don't need it anymore. And it's true, they're not going to get pregnant. But often what happens is they start getting flooding back again because we took the Mirena out too soon. So sometimes what I'll do is I'll grab a random follicle stimulating hormone from them before I remove an old Mirena to make damn sure that it's over, that she's not likely to start bleeding again. Because I think it's like, you know how we're seeing girlies with periods starting 9, 10, 11? We're also seeing women having persistent regular bleeding, 55, 56, 57. So the reproductive window is actually getting bigger, which maybe is the reason why we see endometrial cancer rates off the charts lately. Some of that has to do with the BMI being bigger now than ever before, I'm sure, you know. But it's interesting that we used to be surprised if someone was still getting periods at 52, 53. Now it's quite standard.
Okay, it just shows you. If you do have a patient getting breakthrough bleeding and they're on their HRT patches, what are your thoughts? How should that be managed?
So probably the commonest cause of breakthrough bleeding is noncompliance, which is one of the pitfalls of giving the estrogen and the progestogen separately.
Okay.
But if they're on something where the compliance is built in, like say Everol Conti, and they're getting breakthrough bleeding, something is wrong. Either there's not enough progestogen getting into the blood to support the womb lining and keep it bound up inside of her and minimally thick. It could be that the bleeding is a result of some other pathology, like a fibroid, a polyp, or God forbid, a cancer. And that has happened a few times. So people like that really do need to be assessed by the prescriber. They should ideally have a bimanual examination and a speculum exam to make sure there isn't a ruddy big polyp trying to make its way out, or some gross looking frank cervical cancer, which can happen, and that can cause bleeding, irregular bleeding. People are often encountering new partners in later life, perimenopausal years. So it's actually a good idea to get a chlamydia test and a gonorrhea test for someone with de novo irregular bleeding who hasn't been bleeding on our HRT prior, because she might have picked up a sexually transmitted infection. So each case has to be taken separately. Ultimately, what I do is I bump up the progestogen temporarily while I'm trying to get a scan. Good luck with that, so that I can get a sense of what's happening in there. And then depending on what I find as a result of the scan, I may end up either referring her to ambulatory hysteroscopy, or if she's not able to tolerate that, maybe straight into gyne OT for like an evaluation under anesthesia.
Okay. If you have a patient who gets pregnant while they're on HRT, do you continue?
Happens all the time. So with the POI ladies, we give them a choice and we offer them estrogen every day. That should never be interrupted, but we give them a choice. Do you want to go on progestogen sequentially, a couple of weeks on, a couple of weeks off, or all the time? Because typically POI ladies don't bleed regularly. If they're actively hoping to get pregnant, we usually suggest that they use the progestogen 2 weeks on, 2 weeks off, because that gives them the best chance of spontaneous conception. If they go to clinics abroad, as they often do for donated eggs, donor egg pregnancies, they put them on massive quantities of sequential HRT, usually oral estrogen, 8 milligrams. Okay, so like the equivalent of 200 micrograms, 300 micrograms of transdermal estrogen, and they leave them on that cocktail for the first 3 months of pregnancy. to support the donated egg. So it's not a dangerous thing or harmful thing in any way if someone gets pregnant on HRT. But obviously, if someone doesn't want to get pregnant on HRT, that discussion has to be had before the event, you know?
Different question. Okay. So you have a patient who's had their uterus removed. And what would you recommend for the hot flushes and the insomnia?
It depends on why she had her uterus removed. So if she had it removed because of
Precancerous cell and family history of breast cancer.
perfect. So precancerous cells in the uterus, presumably. Yeah. So
Yes.
if you were to scroll back to that red light, green light table that I showed you from the British College of Obs-Gynae, it shows all the different kinds of womb lining cancer, the stages and the grades. So depending on whether she was high grade early stage, in which case I'd be very happy to give her HRT, or low grade late stage, I might not suggest she use HRT because even though the womb is gone, there might have been some residual precancerous cells lurking in the pelvic cavity, and she might be better off avoiding estrogen at all costs. So it kind of depends on what the stage and the grade of and the type of endometrial cancer was. And usually I'll write to the gynecologist and the oncologist and just we'll have like a little group chat about what's the best way to proceed. If she herself does not want HRT, or if her specialists are really throwing up hurdles, we would go down that big grocery list of the SSRIs, the CBT, the venlafaxine, yeah, yeah.
Okay, work your way through.
And
Okay, if
VOs are
you,
fine for her.
yeah, true. If you have a patient with reflux, what kind of strategies would you
Just
recommend?
use,
Change the
just
time
the
of the
usual.
drugs
Yeah,
or
just don't take them orally. So
okay.
use your patches, gels, sprays, ideally for your estrogen, and use your utrovaginally or a Mirena because everything else you kind of have. Well, Everol Conti, you can use that transdermally. It doesn't tend to worsen reflux. The problem in Ireland is we don't have the bleeding version of Everol Conti. So the Everol Conti brand is specifically for people who are no longer menstruating, no longer bleeding. The Everol Sequi brand, which is available all over the north and in the mainland UK, that's appropriate for people who are using estrogen, progestogen patches combined who bleed. But there's no reason why you can't make Everol Sequi. So 2 weeks of Everol followed by 2 weeks of Everol Conti is Everol Sequi, if you can follow me. So we just hash it together. That's a MacGyver one.
Yeah, mix and match as you need.
Mm-hmm.
A
There's
script for
method in the madness sometimes.
yeah,
Sometimes.
that makes sense. I mean, you're
Yeah.
getting the same results in the end, I guess.
Yeah.
The script for a lady on estrogel with 2 pumps 3 times a day, is that very high?
That's very high. So 2 pumps is 50 micrograms. So 3 times a day is 150 micrograms. So they'd want to have a really good reason for doing that. So the only people I have in my own practice that I would have on that dose would be girls under 40. So if somebody was very young and wasn't really getting much impact from symptom control with 100, 75, 100, I'd try 125, I'd try 150. You regularly see the POI girls who are contemplating donor egg on 150 microgram doses like that. But if you're talking your standard 45 to 55 plus lady, that is way too much estrogen. And there is a kind of a kind of a negative, what will I try to say? Like the more estrogen you provide, even transdermally, the more impact it'll have on sex hormone binding globulin. And the higher your sex hormone binding globulin protein, the less estradiol that's free to get into the cells. So more is not always better when it comes to the older woman looking for good symptom control. And changing delivery system is usually the best option there, not going high, high, high with the pumps.
Okay, yeah, that makes sense. If you have a perimenopausal lady who believes she's perimenopausal and she wants to go on HRT, is that okay, or is there any risks if
Yeah.
it was if
Patients
she
almost
wasn't?
always self-diagnose these days, and they're almost always right.
Okay.
Every once in a while, you'll meet somebody with symptoms that just don't smell right, like that lady with the flushes. The heat and the flushes weren't coming in waves. It was like all the time. So we knew something pathological was happening there. She was the lady with the abscess. I met an older woman years ago who had persistent flushes and sweats and the most intractable skin itch I've ever seen. And she'd been to 2 or 3 dermatologists and been on a million different products, some of which had to be imported from Germany. And it was only after we done a chest x-ray, we realized she had a massive mediastinum and a lymphoma cancer. So, there are weird cases where what sounds like menopause is actually disease. But generally, you saw those symptoms. If you're getting the odd flush and sweat, a bit of disruptive sleep, crankiness, irritability, depression, anxiety, dryness in the vagina, all of that other stuff, that's perimenopause.
Okay, so you're good to
Mm,
go.
yeah.
A question from the Vagifem. A local menopause specialist had very high doses, often every second night, sometimes every night. Is that okay?
It generally, yeah. So the licensed dose of Vagifem for maintenance is actually quite low. And a lot of women do need more. Now, me personally, I'd rather use one of the other products than go with Vagifem, because it's such a fiddly pain in the neck to put the damn things in. So Vagifem and Vagirux are estradiol, E2. They're good for vagina symptoms, but they tend to cross the vaginal membrane a little bit easier than E3. And when they do get into the systemic circulation, they're not as well bound to proteins as estriol is, E3. So I would rather something like Ovestin or Blissell. Blissell is my favorite at the moment for people who are not getting good symptom control on Vagifem, rather than giving them ever increasing doses of Vagifem. But I mean, I remember years ago, Professor Guilbeault, he's long retired. I hope he's still alive. He said if you put a Vagifem in your vagina every single night for a year, it's the equivalent of swallowing a single estrogen pill, 2 milligram pill. So like, don't sweat it.
Okay, fair
Yeah.
enough. Okay. And this question was if a patient was on 400 milligram progesterone for 2 weeks instead of like 200, and they're on 2 pumps of estrogen, why would
That's
that
too much.
be?
That's too much progestogen. There's something going on there. I don't know what it is. So either a misinterpretation of the guidelines, because these guidelines are very clear and they're in all the BMS, IMS, all of the guidelines. The Menopause Society of Ireland has information about how to prescribe the estrogen and the progestogen together. Maybe it was that the lady was on the standard 2 pumps of estrogen and a 200 dose of utrogestan, but she bled. So they were like, you know what, let's shut this down with a higher dose of utrogestan. I could see rationale for that, but you wouldn't leave her on that long term. You would just do it temporarily to see if it helped. Because a good way to make sure that unexpected or undesired vaginal bleeding is non-pathological, can I control it with progestogen? And if the answer is yes, then 9 times out of 10, it's safe. It's not cancer, you know?
Okay. How about the effects of Ozempic on HRT dosages?
Yeah, pretty good. So we've been approached by Professor LaRue, who runs the obesity management services in Vincent, was working in Vincent's hospital. He doesn't run them. There is, because Ozempic, Mounjaro, all of these GLPs, they seem to have anti-inflammatory properties beyond the appetite suppression and the good sugar metabolism benefits that they convey. And he wants to do a study where women who've experienced weight gain in menopause, not obese women now, women whose BMI is still within 25 to 30, we're thinking of trying a little bit of microdosing of Ozempic, like well below the 1 milligram, because there is research internationally that suggests that actually can help with flushes and sweats. And he's particularly interested in maybe offering it to people after breast cancer, because a lot of people with flushes and sweats after breast cancer, either from the tamoxifen or from the aromatase inhibitor, or just because somebody pulled all their HRT off of them, they gain weight. And when you say to them, God love you, you've had a rough year, you've had the chemo, you've had the wide local excision, you might have had the radiotherapy, now you're on some wretched estrogen blocker. What's your number one problem that you want to get help with? It's the weight gain.
Okay.
Mm.
Okay. Can you be on the Evrel Conti if you have a Marina coil?
Yeah. So if your Mirena coil ran past its 5 years, it's still good for contraception and it may still be keeping heavy bleeding under control, but you can no longer get away with just taking estrogen. Now you got to add in supplementary progestogen. And one very convenient way to do that is with Everil Conti. But if you have somebody who's wearing a Mirena that's less than 5 years in there, why on earth are they taking additional progestogen they don't need? That doesn't make sense.
Okay. We've a lady in her mid-40s on the estrogen patch, 100 micrograms, with a few years of night sweats, and the dose was titrated up slowly. is it okay to stay on the high dose, or do you recommend that they come back down
No,
again?
so long as she's getting good bleed control with her progestogen, she's on the appropriate amount of progestogen. So once you raise up the estrogen, you must counterbalance that with a raised Utro, Dufastin, whatever. Not Mirena. Mirena is good till about 125. So a Mirena will keep your womb lining safe even at doses of 100, 125 of the estrogen. So I don't know what this lady is using, but if she's using an oral or a transdermal estrogen, it has to be dose appropriate. Um, Bring me back. What's the question again? I lost
That's
my
much. Could she be on both?
Yeah. So say the whole question from the start.
Uh, so
45,
she was in her
100.
mid-40s, she's on the estrogen patch and it
Yeah.
was titrated up. And was it okay to stay on the high dose, or should you
Yes.
bring her back
So,
down?
so I need to know what her progestogen is just to be safe. But it's quite possible that from about 45 to at least 48, 49, 50, she may just require a higher dose. And if it's getting the job done, leave her there. Now, I wouldn't push her, but I would say to her once she turned like 50, 51, it may be that your need for estrogen isn't quite what it once was. Would you be willing to try, even for a few weeks, coming down a little bit? And a lot of people are happy to do that because we don't have a lot of long-term data on the safety and the risk benefit profile for people on large doses of estrogen. All the current studies, that RCT studies, are based on low doses of estrogen or oral, like Femitab, that kind of a thing, Famoston, and transdermal estrogen 50 and below. So we don't have tons of 10-year observational data on people using 75, 100, 125. And we're frightened. We're afraid that in the generations to come, where this kind of heavy-handed estrogen dosing, prescribing, could actually come and bite us in the backside when it comes to endometrial cancers.
Yeah, I know what you mean. How about Vagifem being prescribed 10 micrograms every night?
That's like what we were talking about before.
Mm.
My feeling is if she's not getting efficacy from the standard 2 full weeks of nightly and then two, three, four a week thereafter, change the product. Don't just keep throwing more and more Vagifems in there. A lot of times, the atrophy responds to the Vagifem, but there's nothing in Vagifem for moisture. And there's nothing in Vagifem for lubrication if you're having penetrative sex. So the nice thing about Blissell is it does all three of those activities. Like if you're using Vagifem and you're still sexually active, or having any kind of penetration, you need a moisturizer and you need a lube as well. So more Vagifem wouldn't be the answer in those situations.
Okay, how long on average should the menopause last?
We used to gaslight people and tell them, well, you'll have a hard 2, 3, 4 years, and then everything will just get easier and easier. And by the time you hit 60, it'll all be over and you'll feel as well as you always did. Lie, lie, lie. Okay. So we have women deep into their 60s and beyond who every time they try to wean off the HRT, okay, yes, they get a resurgence in the first couple of weeks, but it doesn't abate. They never get a clean night's sleep when they're not on their HRT. Moreover, we know that people who get persistent vasomotor symptoms, flushes, sweats, that kind of trouble, later into their late 50s, early 60s, and beyond, are far more likely to have heart attacks and strokes. So they're the very population we want to leave on HRT because it gives primary protection against cardiovascular disease. So I never tell anybody to come off HRT. That is a personal decision. I do advise them and just remind them that the longer you stay on HRT, theoretically, the slightly higher risk of eventually being diagnosed with breast cancer. Part of that could just be longevity, because we know the longer you live, the more likely you are to be diagnosed with breast cancer. And then the fact that it's such a common cancer that if you're taking an estrogen at 65, 70, 75, 80, and some precancerous estrogen sensitive tumor cells start to grow in your breast, chances are they'll manifest sooner in the presence of HRT than they would if you were not on HRT. But my feeling is it's a personal choice, and I think that is the consensus among experts.
Hmm. Going back to our lady from earlier, the older lady, where the GP had taken her off the HRT because she was an older lady.
Yeah.
the patient wants to go back on the HRT. So how do we handle that GP?
When I say to my lady, or like I do a lot of work, like with say Sally Ann Brady, who runs that Facebook group for people going through perimenopause and menopause, and we do podcasts. I say, listen, it's hard enough to get a GP, let alone a really good one, and one who listens to you when you say, with the greatest of respect, I've done some reading and I've read the book. Like there's a lot of good menopause books out there. And I don't think I want to be on HRT. And there is no rule that says I have to come off. Why are you insisting I come off? What I'd ask them to do respectfully to that prescriber is say, I heard from my pharmacist or I heard from a menopause expert that I could actually stay on it. Would you be good enough to write to the local complex menopause clinic and just get some clarity on this for you and I, because I think we have a disagreement here. The easier thing to do, if you don't want to fight, is to find the local family planning or well woman clinic in your area and just book an appointment with one of the seniors. So in Dublin, you're looking at Katrina Henson or Shirley McQuaid, somebody like over 40 who does menopause in a family planning well woman clinic, and just say, I want to get a second opinion, because the beauty of HRT is now it's free. So you don't need that medical card GP to give you your prescription if you want to go back on it.
Oh, that's good.
Hmm.
With women who had significant brain fog during the menopause, do they have a higher risk of dementia?
No.
And therefore, aside from HRT, is there anything else they could be taking to
Yeah, that's a
support
really good
themselves?
question. So we have no evidence to suggest that brain fog, as is commonly experienced during perimenopause and menopause, is a herald of future cognitive disease. Not at all. What we do know, and most of the research is coming out of the University of Chicago from Professor Pauline Mackey. She does great publications and studies. There is no direct correlation between brain function, cognitive ability, verbal memory, that kind of thing, and estrogen. All people, men and women, hit 40, 45, and their brain function falls off a cliff edge. And then gradually over the next 10 to 15 years, it resets and comes back quite good. If somebody is getting a lot of sleep disruption, that'll make the cognitive decline, the cognitive problems worse. So how HRT can help with verbal memory and brain fog is it makes you get more restful sleep. So if somebody wants HRT for cognitive ability, but they're getting restful sleep already, I kind of mute their expectations and say, chances are HRT is not going to bring you back to where you were when you were 35, 40, and only time will tell. But the good news is it does not mean you're higher risk for dementia, presenile dementia going forward, But then if those people have dementia in their family, they can be very upset about getting cognitive decline in perimenopause, understandably,
Makes sense.
Yeah.
A patient on Neutrogestrone 100 milligrams orally and then one capsule vaginally to avoid side effects. Is that okay?
I do it all the time. So if somebody's on a higher dose of estrogen or bleeds quite easily, they don't get by with just 100, they need 200. But if you give them 200 orally, they can't get out of bed in the morning. So we break it up. We say 100 because you like a little bit of soporific effect. Take it orally, but we put the other 100 in vaginally. And recently I've heard of a lady who insists upon taking it rectally. Now, are all the Utros licensed for rectal use? Of course not. No one's ever done that study. But it makes perfect sense that it should be just as effectively absorbed into the mucous membranes and over into the systemic circulation, whether you pop it in your vagina, your backside of your mouth.
Okay, fair enough.
No other cavities. No other.
Cavities good. Well, but good blood perfusion. You may have covered this already, but anyway, I'll say it. So, a patient with a history of sarcoma has infused HRT, but has bad symptoms such as sweats and depression.
I don't have a lot of sarcoma patients, but it does not ring any bells. There's no alarm bells saying that that's a highly hormone sensitive tumor. So that person could be referred into a complex clinic. And if she's in my catchment area and she wants HRT, chances are she's getting it. Now, the oncologist might have identified receptors on the tissue cells, the tissue that was extracted. I don't know, but I want to see that histology.
Okay. The product you mentioned that was a preferred alternative to Vagifem, what did you
Blissell.
say?
Blissell. So Blissell only recently got licensing for the drugs payment, medical card, and the free HRT scheme. As you know, Invagis, those little waxy pessaries, they're gone. We can't get them anymore for free. But I like Blissell. It's a bioadherent, a mucoadherent gel. It comes with an applicator, just like Ovestin, but you can use your fingertip equally. It's perfectly acceptable. But what's different about it is, unlike Ovestin, which kind of trickles out of you if you stand up and go to the toilet, the Blissell sticks to the lining of the vagina, and it's much more effective for lubricating and moisturizing the tissues.
And we got some feedback there on that query we had earlier on the VOSA and the breast cancer patient where the oncologist had taken her off. So the oncologist said there was trials that they'd benefited patients with very severely affected hot flushes. And basically this patient didn't warrant it as hers is moderate.
Well, that's not their decision. That's the patient's decision, I would argue.
Okay.
Like, there's how many flushes and sweats you get and how high you score them on a scale of 1 to 5 has less to do with how we prescribe and more to do with what impact are they having on your days and your nights. And if they are messing you up, I don't care how many you're having or how bad they go on the scale. If they're bothering you, they need to be addressed.
Okay, so it's the quality of life factor that really needs to be prioritized over the research. Very good. A patient on transdermal estrogen, 50 micrograms for 5 years, and Marina, but has never gotten relief from the insomnia. Any recommendations?
Oh, okay, that needs to be addressed. So some people have shitty sleep habits. They're looking at the phone for the last 2 hours. Now it's 1 o'clock in the morning. They get 4 good hours, and then that's it for the rest of the night. So sometimes sleep hygiene needs to be recalibrated. And the best way to do that is with an app or an algorithm, and you can get loads of them for free online. But obviously it requires a certain amount of compliance. The other thing I'd want to know is the sleep a flushy and sweat thing? Are they actually getting full vasomotor relief? And if the answer is no, then we need to look at another way to deliver that 50 micrograms, whether it's a gel or a spray or whatever. And then if they've tried loads of different estrogens and the 50 just isn't getting the job done and their sleep is disrupted because they're still sweating and flushing, we need to go higher. That's just all there is to it.
Okay, perfect. And then HRT, would you recommend it for a patient who's suffering from UTIs?
Not the systemic HRT, but certainly the local
Just the
vaginal stuff.
local. Okay.
Yeah, in fact, they did a couple of studies in Germany and one in the UK where women in nursing homes who are wearing adult diapers, long-term care, incontinent, mobility disorder, were being given a little bit of Ovestin a couple of times a week during the toileting, and they cut down on the UTI incidence by over 50%.
Wow.
So you're never too old, or it's never too late to try some local vaginal estrogen. Significantly beneficial for recurrent UTI.
That's good to know. Deirdre, we have covered all the questions.
Hard, but it was fun. I really enjoyed it. And thank you.
You are a pleasure to listen to.
I'm always humbled by people who work all bloody day and then manage to come online for this crackology at night. So big respect to you guys for making time for me.
I think you have really compounded our learning. Guys, you might remember the survey there for the IOP, but I've definitely have a much clearer perception of what I need to know and what's essential and which products for what than I did at the start. So hopefully everybody else is feeling the same and has taken good learnings away from it, which you can now jump on and do your CPD cycle and get that started. And sometimes doing the brain dump of all that material onto people can really
join Pharma Buddy.
Learning.
If you're not already at Pharma Buddy, it's free. Join it. Paul would love to see the numbers increase. And then you can contact me directly through. I can't do instant messaging on Pharma Buddy, but I look at Pharma Buddy every day. So you rarely go more than a day or two without getting an immediate answer to your cases. And then the other thing is, by all means, it's like €100 a year, and you get the meeting for free if you join the Menopause Society of Ireland. So do that as well if you're interested.
Brilliant. Thank you. Now, while I have you still online, guys, just a quick reminder, there's a special edition webinar on tomorrow, and it's the introduction to the Common Conditions Service. So there's a good few people going to be running that session for us. So Catherine Kane, Head of Medicines and Controlled Drugs and Pharmacy Legislation, Department of Health. We have David Hanlon, who's a GP and the National Clinical Advisor in the Primary Care and the HSE. Dan Burns, Head of Education from the PSI, and Alva in CPD for the IIOP to bring us up to speed what's happening on the new Common Conditions Service. I think that's definitely one for us all to dial into tomorrow evening. If you can't find you should have it in your emails to register for it. If not, it's in the homepage of the IIOP website and you can register for it there. Then the next session we're going to have is on Wednesday the 19th. We have one on fertility drugs, which is another one of those tricky topics, which is great to have. So David Fitzgerald will be speaking to us on that one. So that's brilliant. So thank you all, guys. I know we've run way over, but I think the conversation was going so well, and I think we were all learning a lot from it. So thank you so much, Deirdre, for your time this evening, and thank you all. Probably see you all again tomorrow night. So thanks, Deirdre. It was a
Good night,
wonderful
everybody.
session. Really
Thank you.
appreciate it. Thanks a
Bye,
million.
girls.
Bye,
Bye.
everyone.